opportunity to for a custom design and custom planning of the aligner treatment in conjunction with MARPI. MARPI is done for aesthetic reasons. MARPI is done for wellness reasons, for improvement of the nasal breathing. And of course, one of the major parts here is to plan the aligners accordingly to be able to control the roots, to be able to move the roots along the midline, and to be able to close that gap efficiently. And the shape memory aligners are the aligners that are directly printed in our in-house lab with the graphy material, which is the graphy resin. And the treatment, the sequence of planning and producing, it depends on the expansion amount. It depends on the, we do take facial scans with our CBCT machine. We do position the nasal, the incisors and the incisor roots according to the superimposition of the facial scans and the CBCTs, because the CBCTs itself, it does not give the accurate information on the relationship to the smile. So there should be some kind of a superimposition between the actual facial profile and the bone, so that we can plan accordingly. Because the main point, and is the aesthetic area, we have to plan that the midline is right where it belongs. So this is the effects of the closure. And as we know, with the midfacial expansion, you were able to appreciate that we get a lot of bone separation. And what happens there, this is the area where we get a lot of we just get an empty space which is filled with the connective tissue, and which has to gradually solidify and be replaced with the newly generated bone along the suture connections position. So this is the area where we have to be extremely careful with not forcing those roots into the expansion space, and be able to gradually tilt and tip the crowns of those teeth, and to then follow with the roots. So the type of movement highly depends on the amount of expansion. And if we, for example, expand less than 5-7 millimeters, which is which still produces drastic wellness effects in terms of nasal breathing, we do have a specific protocol with less tipping and with more aesthetic outcomes in terms of more parallel incisor movement. So the shape memory aligners and the material that we use, the graphy resin, this allows us to reduce any need in attachments, in additional bonding and removal and polishing of tooth surfaces, while the resin produces elasticity levels and the physiologic levels of force that allow for very efficient, within almost 3 months, closure of that interdental space produced by the expansion. So this is one of the cases treated with the shape memory aligners with the resin by graphy, and we expanded this patient by 11 millimeters. And what happened is that the patient asked us for aesthetic purposes to cover the space with some temporary composite. And what we were doing, we were just gradually shaving down that composite and closing those gaps. And you can see this is just the effect of almost 3 months of closing, and he still does have some composite left, but this is how the aligners, the shape memory aligners, look from this is the maxillary occlusal view, and how the gap progressed, and how it was continuously being closed with shape memory aligners. And this is how the actual planning happens. And we do this with the NemoCast, NemoFab software from Nemotech, from the Spanish company. And this shows us some buildup of the composite that was used to camouflage that gap temporarily. And this our software that allows us for all 3D planning of the tooth position, of the root positions, and the relationship to this midfacial separation. This is the process of actually producing the shape memory aligners. We do have printers. We do have several printers in our lab, and this is just a few studies by Dr. Kim from St. Louis University, the chair of the Department of Orthodontics and Dentofacial Orthopedics, that has been conducting studies on the efficacy and the accuracy of the resin. So what those studies show is that the direct printed aligners produce physiologic levels of force within the range of 0.8 or 1.5 newtons of force, which was shown by William Prophet as a physiologic levels of force that are well tolerated by the body. While the thermoplastic aligners that are used with the regular, third-party aligner producing companies, those aligners, they produced way higher forces that may sometimes exceed 5, 8, 7, 8 newtons of force, which is almost 5 times higher than the physiological levels of force. So this is just a video that's showing me, and we have printed this aligner with increased thickness, and that shows that we can modify the design of those aligners and add any additional features to that. And in this case, we just added so-called precision wings, and this is the maxillary part of the aligner. So that part will serve as a part of the functional appliance to produce the mandibular movement. And this is the easiest way to put it in my mouth. So as the aligner, this material is thermoplastic, it depends, the plasticity of the material depends on the temperature. The material can be easily molded and with the higher temperatures, and once it reaches the temperature of the mouth, it gets more rigid, and this is when it produces its effect. So it's just also a 1 month effect of the direct aligner application. This is how efficient they are, and this is the facial effect of midfacial skeletal expansion. This is how drastically face changes with improvement of the skin architecture, with the nasolabial folds and the position of the mandible. Of course, you see the facial proportions, they change significantly, and what I want to thank Professor Constantinescu for allowing me to present here. And these are my mentors, Dr. Stanley Liu, Dr. Von Moon, Dr. Kenji Ojima, Dr. Richard Ting. I am grateful and honored to be able to present here. Thank you very much for this opportunity. You can find me on Instagram, on social media, and this is the website that shows what procedures we.
Dr. Koval, thank you so much for your presentation and for your contribution in Elsevier book project. Thank you so much.
Thank you very much. I appreciate it.
Hello, Professor Bucco.
Hello.
Thank you so much for your contribution at Dent conference and in Elsevier book project coordinated by Sam. Thank you.
All right.
I'm sorry. I'm sorry for intervening. You can press in your Windows bar the presentation, the PowerPoint. It's right under your mouse. The bar but okay, there it is. And present, okay. Okay. Sorry for interrupting.
You can see that okay?
Yes.
Yes.
All right. Well, I'd like to thank you for inviting me to give a talk on this most fascinating disease that I didn't know anything about until the mid-1980s. I wanted to I make most of my lectures for students, and I'm just used to putting hyperlink buttons everywhere. So it's set up as sort of a self-understanding or self-use textbook as well. And if anybody wants a copy of this, my email is at the top, and I'm sure that you would, I can get the copy to you very easily. I'd like to point out something about me. I have been around the block a little bit. I'm now in my 80s, and I've given over 1,800 talks in every state in the United States. I have retired to live in the mountains on the eastern part of the United States by Washington, D.C. And I have given a lecture, I remember, in Serbia and one in Hungary, but never in Romania. So I guess technically this is a first. I've written a lot of papers, and a lot of them have been cited, but one of the things that got me started was this fourth line down. I went to the Mayo Clinic, which at that time and still today was one of the two places in this country, in the US, that has the most bone surgery and the bone pathology. And David Darlene had the standard textbook. He was the chair of the Department of Pathology. He had the standard textbook for several decades on bone tumors. So I'm a dentist, and I applied for his fellowship because I was interested in bone. And he only takes one fellow a year, and we got to know each other very well. And toward the middle of that, he admitted that he just took me because of my audacity, I guess, dentists wanting to learn bone pathology. But in fact, it has been one of the best things that I've done, and I've kept my interest in forever. And relative to ischemic bone disease, it's mostly a medullary disease, but the bone itself can be involved, the hard structures. And I went the whole year in bone pathology. We saw about 50,000 cases of bone from the surgical suites at the Mayo Clinic during that time. And Dr. Darlene was very well established, and he developed about, he was getting 10 to 15 consult cases from all over the world every day, and it was my job to set them all up. And of course, the last thing I had to do was write out my diagnosis. So we saw a lot of bone pathology, and I do not remember ever seeing anything that we called ischemic osteonecrosis. And that was back in the mid early 70s. And it was the late 70s and early 80s that finally pathologists got involved in this whole disease. And we discovered that actually it is a disease not of inflammation, but of poor blood flow. And that makes all the difference in the world. So let me talk about this. This is chronic ischemic medullary disease is a name I kind of had to make up for it, for a broad category that is often called ischemic osteonecrosis. But I have maybe 12 different categories, microscopic categories, and probably half of those, the bone is perfectly fine. It doesn't look dead in any way, shape, or form. But about a couple of years ago, I was reading, just for my own benefit, a journal, and it was talking about bone diseases that they have found from fossils. And I discovered that ischemic marrow disorder, ischemic bone diseases were a big time problem for dinosaurs 100, 120, 200 million years ago. And I'm just fascinated by that connection. So that's where the title comes from. And let's go a little bit into the history of these. This is a disease now that's very well established. It's responsible for up to 30% of all the hip bone replacements in this country. And it used to be called osteoarthritis. And as a matter of fact, today, people have looked at the bone marrow under osteoarthritis, and it's dried out. It's desiccated, it's diseased, it has poor blood flow, even stagnant blood flow. And most of the time, almost always, it is seen before the overlying cartilage and outside bone, the cortical bone, is affected. So technically, it is something that is an ischemic disease, even though we call it osteoarthritis. It may not be a wear and tear problem at all. It may be an age-related blood flow problem. But it's very well established, and we'll talk a little bit more about this and compare the jaw lesions with the hip. Today, it is essentially, even though up to a third of hips are replaced because of the diagnosis of osteonecrosis, all the rest are osteoarthritis. Almost all the rest are osteoarthritis. And as I've just said, it all starts with the drying out of the underlying bone. So let's talk first about the dinosaurs. I don't mind busy slides myself. Might be part of a psychological problem I have, but I have this available, and you can read while I'm talking if you wish. But I first discovered this disease when I saw a book on a library shelf called Dysbaric Osteonecrosis, and I had never heard of that disease. And so I pulled the book down, and there was a chapter on the pathology, the microscopic features. And for the first time, after looking for 4 years to try to figure out what this disease was that I was trying to diagnose in the jaws, I essentially let out a verbal, "Hello, this is it." It was late at night in the library, so nobody else heard me, but I was very excited because I looked at the pictures, the microscopic pictures, and they were exactly what I was looking at. Stuff that I had been calling for 4 or 5 years osteomyelitis, and it wasn't. Well, if you're a professional diver today, pearl divers, for example, in Japan, up to 71%, one paper had 80% of those people will get this disease in their skeleton during their lifetime. And often it is a very debilitating thing and forces them to find a different job or retire. But when we get to the dinosaurs, the ichthyosaurs were around 220 million years ago, 200 to 220 million years ago. They were deep diving. They would go down hundreds of feet. And when people look at the bones, there are certain features of this disease that cause a very diagnostic destruction of the bone that allows that to make that diagnosis to be made in fossilized bone. There just aren't very many diseases that you can diagnose today in dinosaurs. And the ichthyosaur really technically wasn't a dinosaur, but it was up to, 12 tons in weight. So it was a rather large creature. And there was another creature involved. If we look down at the bottom, the Mosasaurus is more of a reptile than anything else. But nevertheless, the problem is they were diving. And just like human deep sea divers, they had this problem. And up to 2/3 of the spinal vertebrae in some of these animals have been found to be involved. And here's a nice example of a fossilized little indentation. We used to call them subchondral cysts, and we thought that it was from pressure on the joint, just pushing and pushing down until it finally perforated through. But in fact, it is from pressure from the fluid in the joint space. But you have to have almost destroyed cartilage and bone, very desiccated, and then it pops down into a hollow space. And that hollow space is really key to the diagnosis. There's only, from all of my reading of thousands, literally, of articles and textbooks on osteonecrosis, I can only find one disease that will create a hollow space in bone, and that is osteonecrosis. You can see some of them. Sometimes you can see it with osteomyelitis, but that's only when it has osteonecrosis connected to it. So, interesting thing. And as it turns out, here is a museum piece at Tyrannosaurus Rex. She's quite a famous one. She's called Sue. And some scientists just happened who knew about bone diseases just happened to go in and said, what are all these holes in the jaw? And they did some studies, and the only thing they could find was trichomoniasis, I'm sorry, is how we say it over here. It's a sexually transmitted disease. And in humans, it's easily handled with antibiotics. It's a protozoa that responds to antibiotics. But in birds and cattle, which it is more common in, it can destroy essentially the whole face. So here's one disease. I'm not going to talk any more about it, but it's just one of, what have we got? 6 diseases that we can diagnose in dinosaur bones, facial bones, and other bones. And osteonecrosis is one of those, and osteoarthritis is another. Well, let's get to humans. The first report of this was in the hip, and that was back in 1790. And in dentistry, one of the great, actually, scandals of the 1840s to the 1880s, dentistry was just starting out. There were no x-rays. We didn't cause these phossy jaws. We were the ones who actually caused it to become a public factor, facet. And it became a problem because this was a safety feature. We were using white phosphorus, mined white phosphorus, and factories in Pittsburgh and Pennsylvania in our country were just filled with young teenage girls whose job was to make safety matches. Wonderful thing for society to have safety matches, but the white phosphorus destroyed the bone. And this picture on the lower jaw did exactly what it does to the hip, but did it to, did it to the jaw bones. And it turns out that it has a special propensity to settle into areas of low-grade inflammation. And in the human body, that's primarily the gingival tissues, the gum tissues. So this became a phossy jaw, is a diagnosis that was given to it by the dental profession. And the dental profession back then was mostly made up of MDs. And it was not too long into the phossy jaw business. We had teenage girls who were losing their jaws from this. The dentist would pull a tooth, and that's what happened with this lower picture, and the whole mandible would come out. Very serious, very debilitating disease process. But the kind of ischemic osteonecrosis that I'm talking about today is not phossy jaw related. It is, for want of a better word, non-phossy jaw reported. And it was first published in a dental journal in 1867. And in there, that physician who specialized in dentistry even put a treatment in. Go in and cure it out of the bad bone until you get some good hemorrhage and good fresh raw blood. And then one of the fathers of modern dentistry, G.V. Black, one of the great fathers of modern dentistry, wrote a book on pathology the year that he died, 1915. And he wrote a chapter after his osteomyelitis chapter called chronic osteitis. That was a name he gave to what I would call ischemic osteonecrosis. And he specifically said, this is very strange. It doesn't seem to be an infection. The overlying soft tissues don't get all inflamed. You don't find pus in it, and you find these hollow spaces. And then in 1932, at the University of Chicago here in the States, the word cavitation was coined by one of the great bone pathologists of that era. And he made it up for the hip, but he specifically was the first to say that there's only one way that this can be created, and that's from poor blood flow. And then in the 70s, when I was well experienced in teaching a lot of bone diseases, Ratner and a fellow in my state here, Roberts, wrote papers where they tied the pain associated with this process to facial neuralgias. And they were very much crucified for their research, but they were published. A lot of people thought it was nonsense because they would look at the x-rays and see nothing. And it turns out we know why now, because it's a bone marrow problem. Bone marrow is not picked up by, bone marrow issues are not picked up by the radiographs. And the first path report was the one that I presented. I gave it a name, NICO, because of that neuralgia connection. I wanted to make a name that was worthwhile, so I said it is neuralgia inducing, meaning it creates a pain that is similar to neuralgia. It has these hollow spaces, cavitational, and it is ischemic. It's osteonecrosis, not osteomyelitis. And then, of course, I started writing about this, and I was the one who got hollered at by my colleagues and people who were not in pathology at all. So I wrote the first histopath description of this in the JAWS, and that was in 1992, and I changed my mind quite a bit as I've matured, and to this date I've seen about 16,000 bone marrow samples from every state in the US and from about 8 other countries. So I've seen a lot, and I think I'm pretty much on top of that game. One of the most current features of this was finding out. We finally, for the first time ever, had tests that would tell you if you had coagulation problems. And that would, I call them hypercoagulation states. I read a paper about this. 72% of the hip patients had this, and for the first time, this was a logical explanation as to why this disease develops. It turns out that if you have these inherited states, there are about 18 now that we know of. If you have them, it creates most of the time small clots, and the two tissue types most susceptible to small clots are brain tissue and bone tissue, bone marrow. I also published the first cadaver study of this in 1998. This was a man who was so thankful to me for properly diagnosing it that when he committed suicide for depression issues, he, in his suicide note, asked his wife to send his head to Dr. Boko. So I've had some interesting experiences with this. Before I go on, let me talk about pain. In the hip, about 70% of the time, this is associated with pain. The rest of the time, people find out about it because they have their hip collapses. They're walking along just fine, and all of a sudden their hip collapses, and then they have the pain. So you can have the entire center of the femoral head either made of mush or very, very thin and brittle trabeculae, or nothing at all, just a hollow space. Well, I don't want to have you assume that this is the only kind of ischemic osteonecrosis that we have, this NICO business. We've known since the 1940s about radiation damage. If you were irradiated for a tongue cancer, for example, it would go through the mandible, and at one point, 1 out of 4 patients would have osteoradionecrosis. Nowadays, that's down because of multiple ports and much better control of the radiation. That's down to less than 1% of patients get osteoradionecrosis. But the main problem is it cuts off the blood flow. And of course, we've known about dry sockets for thousands of years, and the name should have told us something was going on that had to do with blood flow. It's not an infection, it's an ischemic phenomenon. And then we see with some frequency little white flecks or cloudy patches on x-rays. And in the long bones, they call those bone scars. They've assumed that that was a reaction to an infarct. And once there, it seems to remain in place forever. We get the same thing in the jaw, probably for the same reason. And we call it either idiopathic osteosclerosis, or I prefer ischemic osteosclerosis. And nowadays we have bisphosphonates. For the past 20 years, it's been our big form of osteonecrosis. When the FDA wanted to have invited people to come to their campus to explain just what the devil was going on with this, they were thinking of taking the bisphosphonates off of the market. I was the only American invited, the only private citizen invited. Everybody else there was representing a company that made the products. And I can tell you the FDA was they're chomping at the bit is the expression we would use to take this off the market. But it turns out it's too helpful to maintain osteoporotic problems and eliminate the spread from a metastatic bone carcinoma. So it's too useful to get away from, and just like old Fosse jaw, the main problem is where there's a low level of inflammation, and so the jaws are where it all concentrates. And this picture in the middle is bisphosphonate-related osteonecrosis of the jaws, or we found other medications, so medication-related. And this is where 3 teeth were. It was painful. They did endo, they redid endo, and finally, one after another, they pulled the teeth. It still was painful. And eventually the dentist just used the forceps and pulled this piece of dead bone out of the jaw. So there are other reasons. We've known that tertiary syphilis can perforate the hard palate. Tuberculosis can do the same thing. Cocaine we've known about forever. I published a case of a fellow from Vietnam who came to Houston, Texas, and developed midline lethal granuloma, and you could see that it has destroyed essentially most of his midface. Midline lethal granuloma, we now know, is a form of an inflammatory looking form of lymphoma. Wegener's granulomatosis, this lower picture was the first time a patient came to see me. He was a Supreme Court justice in our state, and this is a through and through perforation into his maxillary sinus. And the white material you see is necrotic bone. It is not pus in any way, shape, or form. And then we've always known about NOMA. If you're starving to death, you have low protein in your diet, your immune system fights off a pneumonia and has no more energy left to fight off the normal bugs in your gingival tissues, and they start to become pathological and start to destroy you. And without antibiotics, you have a 50% chance of dying. So not a good disease, but it has multiple causes and multiple therapeutics. So how common is it? Most common locations are hip, knees, and jaws. Lower spine is another form, another place for it, especially in people who are slumped forward. But in fact, any bone in the body can have this. Where the bone is, where it is, it affects the gender, whether it affects females or males more than one or the other. Typically, just generically, if it's in the hips, 60% are females. In the knees, 50% are females. In the jaws, from my studies, 80% are females. And in childhood, especially young boys who play baseball and football, they injure their hips a lot and trigger this kind of thing if they have those coagulation disorders. So in that particular scenario, 100% of them are males. And that was in the days before young girls were starting to do all the physical things the young boys are. Well, this is fascinating because this is a disease that, from my reading of several thousand papers on this topic, there have been, I found over 72 different names for this disease, starting with that 1790 paper. And here are some of the names on the right. If you have it in your ear, it is so bad that it is called otitis maligna. And that is because if you have it in your ear, you're likely to get it because ear canals are very close to the bone. The mucosa has very little covering. And once the bone it gets into the bone is relatively thin, and doesn't take much to get into the base of the brain. Avascular necrosis of the condyle was written up back in the 1970s, and that is a generic term for ischemic osteonecrosis as well. Chronic osteitis, these are jawbone lesions. Cavitation is what biological dentists in this country use quite frequently. Ratner cyst, Roberts cyst, and cavitational osteonecrosis and NICO are just some of the names that are used for the jawbone cases. And these are others. That one that was seen in young boys who injure their hips is called leg cavitaritis disease, and it has been known to have quite a few different names. One of them, ironically, is in young pregnant women, and they get a transient ischemic osteoporosis and osteonecrosis. It's a focal osteoporosis created by localized blood flow problems. And of course, estrogen pretty much messes up your coagulation issues anyway. It's very well known to do that. And then there's some names that are etiology associated: radiation, hyperbaric deep diving, estrogen induced osteonecrosis, and corticosteroid induced osteonecrosis are formal names for diseases. Alcohol induced in alcoholics, it may not be the alcohol, it may be their diet. And then Sudeck's disease, now called more complex regional pain syndrome. This is a bone involvement in that process. And if you have lupus, at a certain level of severity, you have a 1 in 3 chance of developing osteonecrosis somewhere in your body. And sickle cell anemia has been known to be associated with this. So all of this is part of a disease process that we thought was exclusive to the jaws. And where does it occur in the jaws? It occurs here in the condyle. It occurs up in the tuberosity. It occurs in the third molar areas. It occurs in the angle. And if you look at the thinking of the orthopedic literature, they have this expression, furthest from the heart is where this occurs. And in long bones, the outer edge is fed by the periosteum, blood, but the very ends are fed by vessels that go to the center and then go up and down to the end. And where they turn around and the arterioles become venules, that's where the greatest irregularity in blood flow is, and that's where the clots will settle out. So it's an epiphyseal disease mostly. Periosteal vessels feed the 1/3 of the bone initially when you're young, but when you're my age, it's 1 out of 10. So it's only the very superficial part of the marrow that's being fed by the periosteum. The rest depends on that single vessel that is coming into the middle. So that explains why it develops in the places it develops. It also is one of the few diseases that is bilateral and symmetrical. If you get this in one hip, you'll have an 80% chance of getting it in the other hip over the next 5 years. And when I looked at my cases, did a study of thousands of these cases, about 1/3 of the cases were on the opposite side. It was in the third molar in the tuberosity on the right. Chances are it would be in the third molar tuberosity area of the left. So we know a lot of things that cause these. Here's a little grunge. It's just like mush. You could clear it out of the marrow with your finger. It's so soft. But this is just a listing of the things we've already talked about it. Cancer chemotherapy, because of the prednisolone or prednisone, is still a major problem. Tobacco is a vasoconstrictor. And the serum sickness, if you're given, used to be, we use horse blood for transfusions. And a lot of people, this was one of the issues that developed after that. They got serum sickness. We also have this as a problem when you have hardening of the arteries, and that would make sense as a blood flow problem. If you starve yourself to death, they discovered this with the Nazi concentration camp victims. We see it today with anorexia nervosa patients who die. When we go into their bone marrow, it looks like a gray gelatinous material, and it's called gelatinous marrow. And it's from ischemic changes or damage to the bone. And talking about all these coagulation things, I've written about 10, 12 papers on this. I had to become a semi-expert. But all in all, some of them you've probably run into. Whoop. Some of them you have run into, but right now, what is the hottest one? You've heard of factor V Leiden out of the Netherlands. But right now in this country, lipoprotein A, that's the one associated with lupus, seems to be a major point of research and even communication. Altogether, somewhere between 70 and 80% of people, regardless of where the bone is, where the involvement is, have a hypercoagulation problem. And in addition to causes, there are things that make the bone susceptible, but then you have to have a triggering event. Most of the time it's an infection or trauma or taking estrogen or bisphosphonates, or deep sea diving, that sort of thing. So don't confuse triggering events with causes. It is a pretty significant change, but it's like a multi-hit problem. Well, let's look quickly at the clinical and gross. I've done a cadaver study of about 140 cadavers out of a medical school here in my state. We were out of that. We were able to, using microscopic and macroscopic appearances, we were able to get about 76 that were in perfect shape. No destruction from no gross destruction, at least, from the poor processing. But this is what, these are from the good jaws, and I have x-rays of all of these, and this is what it looks like. It's inside the jaws, and look what it does. The big problem we have with the jaws, that's why the pain, I think, is so closely associated with this, neuralgic pain, is the nerve is either in a little bony canal that's full of pores, holes, but this disease wraps around the nerve. It's right in the area where the nerve is, and the nerve gets brown and frayed, and it splays apart. And eventually you can get some of these that produce a hollow space. This is an entirely hollow mandible, and the nerve was just held in place, the neurovascular bundle held in place by some fibrous scar tissue. And here is the cadaver from the patient who submitted his head to me or sent his head to me, and that was just mush. But look, there are multiple sites of involvement, and if you cleaned out one, it is possible that the pain would not totally go away. And there is, for older people, there is a special susceptibility right here under the cortex as that periosteal feeding starts to shrink back and become minimal nutrition for the marrow. This is normal mandible, and these are just biopsy samples as I received them in my lab. You can see up above the ischemic damage compared to normal yellow marrow. And in the hip, it's the same as what we see in the jaw. Here's normal on the left. And you can get very osteoporotic tissue with little fractures everywhere. We don't get that so much in the jaws, but in the spine and in the femoral head, that's a big problem. And you get collapse, you get dried out areas, and you get the sclerosis. So it's a disease that has a wide variety of gross appearances, and that's why I think we have thought of this as so many different kinds of diseases. By the way, I'm using these pictures from Peter Bulow, and I went up and spent a week with him comparing my jaw cases with his hip cases. He was kind of the standard author of the textbook of bone pathology in the 80s and 90s. Well, so just to make a quick point, this is a study from the 1960s. Somebody wanted to prove that x-rays aren't that helpful to finding bone marrow problems. So they cut a mandible, several mandibles in half, and then they just curetted out at least 50% or almost 100%. And then they glued the bone back together and took another x-ray, and you might not be able to see it here, but I've looked in the original in the journal, and I can't tell the difference between these. They're perfectly normal. It might be a little change in the trabecular pattern, and about every decade somebody has published a paper like this that proves that we should not depend on x-rays. However, dentists depend on x-rays, and it's a natural thing to say, well, I don't see it on the x-ray, therefore it must not be there. Well, from the cadaver study, this is just mush under the nerve, and I put arrows in the same place on the x-ray and the gross. And I would dare you to say that you would see something pathological here. Same with this, which is a completely hollow mandible. And this is that fellow who donated his head to me for research. And you can see that he had a little area that was just starting out. And that's why he died, because he had been diagnosed with trigeminal neuralgia for 7 years. We found 2 places in his jaw, cleaned them out, and the pain was gone. But now it was almost a decade later, and he felt some pain coming back. And he was so afraid of going through that again that he killed himself. So implants are a big deal now. If you took implants and used a trephine the bone, just took a little core sample of bone out before you put the implant in and looked at that core sample microscopically. This was a study not done by me, done by 2 pathologists, oral pathologists at the University of Maryland. And in their paper in 2010, they said that 51% of all the sites had either chronic osteomyelitis or osteonecrosis. And the osteonecrosis was the most common. It was 35% of all of the bone samples. And these were sites that had already been approved. They were just minutes away from having the implant in place. So this is, we're dealing with diseased bone at all times. And we get away with it somehow because the body's able to adapt because implants are pretty successful. But we should not be thinking that we're putting those implants into healthy bone because over half of the time, that's not true. I just finished looking at about 1,600 edentulous sites for something that I call residual sockets. They're areas that the teeth have been out for years and decades, and we look at them and we can see the outline of the old lamina dura. And sometimes most of the time, it is just an area of low bone density with a slight sclerotic rimming or no sclerotic rimming. Sometimes I call it an eagle's nest appearance, where it looks like the sticks at the outer edge of the nest have been just splayed out. So this is a disease that it's made for getting us all in trouble. It causes a tremendous amount of pain. It has, I personally have had 4 of my patients commit suicide. 2 of them called me to thank me for what I learned about the disease before they put a gun to their heads. All of them killed themselves with their husbands' guns. So it is a pretty sad disease, and I wish I could say that it would be great if we could see it all the time, but we just can't. And as if that's not bad enough, some people average, we see only about 12 to 16 shades of gray. The best we can do is see 36 shades of gray, but some of us can only see 6 shades of gray. And if you're on the high end of that, you'll be able to make a better diagnosis of any kind of disease in the jaws. I happen to see 34 shades of gray, so it's been helpful in my career. And look at this, stage 0. This is the only disease in a 7-volume textbook of radiology that is classified radiographically. These are the tests you have to do, and you grade them according to which need the most tests in order to make the diagnosis. But this is the one that has stage 0. By definition, stage 0 means all imaging techniques are normal or non-diagnostic. And the only way to diagnose it is to do a biopsy. And that's what a lot of the biological dentists are doing. They see what seems to be a little abnormality in an area, a little low bone density, irregular trabecular pattern, and they go in there, and sometimes it gets them in trouble because nobody else can look at it and see this. These are just some examples from my biopsies that have been submitted of when people could see these things. A lot of them I would call residual sockets. But this disease led me from my orthopedic research, led me to do several hundred, probably 400 or 500 Tech 99 bone scans, scintigraphic scans. And they've been around since the 1950s, so every hospital has it. And supposedly, if this is positive, I proved by biopsying the hot spots, if this was positive, then 98% of the time there's either ischemic or inflammatory bone immediately under the area of the hot spot, this black spot. And then there was another paper that came out that talked about using quantitative ultrasound at the right wavelength in ultrasound. It goes directly through bone. And so it's been used as a screening technique for osteoporosis for decades now, since the 1970s. And somebody in the 1990s made a product that would be able to be used in the jaws. Until then, we were not able to use quantitative ultrasound. Well, here's bone scan. NIH did a study of this. They tried to prove me wrong, and 79% of their atypical facial pain patients, I left off the neuralgia, but it should be N there, had a hot spot in the area of pain. I did that also, and I found the same thing. I did it out of patients from Indiana in the middle of our country. 79% of 117 had a hot spot We published that, and that was the most often cited and often read paper in the journal, OOO, in the Journal of Oral Path, Oral Medicine, Oral Radiology, and Endodontics during the 5 years after it was published. So people were interested in it. And then we also did biopsies, as I've shown you, and or I mentioned, and only 2% were false positive. And here's a study I presented. I haven't published it yet because I gave it to the FDA for approval of this device. But here is a very minimally something in the X-ray, and it's very obvious with ultrasound. Ultrasound through transmission ultrasound or quantitative ultrasound is only good for three things. It will find low bone density, it will find dry bone, and it will find hollow spaces in bone. And all of those are produced by poor blood flow. So as it turns out, the blood flow in the bones is quite different from blood flow in the soft tissues. It's usually under much higher pressure, and backup pressures are easier to get. So these are just some examples of positive ultrasound, quantitative ultrasound, compared to the radiographs. I don't want to get into the pathology, but there's a lot of it. We had massively dilated capillaries and mostly capillaries, but also veins. We get big bubbles of fat from fat upstream fat necrosis. We get clots that form, and then we get backup pressure that dilates the vessels. And when we get stagnation, all of the red blood cells over a period of weeks disappear or become very pale staining. Ghost erythrocytes, they're called initially, but then they just settle in, and we start to get some platelets and fibrin involved in it as well. So stagnation leads to clots, clots lead to stagnation. It's a vicious cycle. And in this case, the bone is pretty much alive. There's no nutrition going to this material out that used to be fatty marrow. One of the things I'd like to point out is this fibrosis. We used to call it, well, we still call it myelofibrosis, fibers in the marrow, but now it's called ischemic myelofibrosis, and it's a wispy material. It's different from fibrosis in soft tissue, and it is also associated with this pink stuff that has little bits of broken bubbles from dead fat cells. This in Europe is called plasmostasis. In this country, it's called serous ooze, and it's only seen in stagnant bone marrow issues, ischemic osteonecrosis. Bone marrow edema is probably the name that is most often given to this kind of a problem. Well, this is just my categorization of ischemic marrow diseases, and then if the bone is involved, I have a few other names associated with this. And when we come to treatment, I know my time is getting short, but when it comes to treatment, the prognosis is, the treatment is pretty much the same. There have been some people that recommend for the mild cases to use low-level light therapy or photobiomodulation. But in the hip, they just go in before it collapses and cure it as much out as they can, knowing that they leave some tissue, some diseased tissue behind. And they get about 70% success rate, at least temporarily, with that. If we have really bad involvement where the hip is collapsed, then hip replacement is about the only thing that we can have. In the jaws, we don't have that option. We're not going to take out somebody's mandible because they have a third molar area of bone marrow edema. So in the jaws, we go in and cure it, and the surgeons, I've looked at about 140 of these over the surgeon's shoulders, and I just tell them to keep scraping until they get good non-brittle bone where bright red blood is flowing out of it. And then that blood will fill in the hole, the space, the cavitation, and the chances are it will go on to heal. We don't have good follow-up studies of the non-pain cases, but the pain cases are the ones that I've reported on, and we had about 72% lack of pain 5 years after the treatment, although 40% required a second curettage in order to effect cure. And some of those treatments went out to 18 years. So it seems to be an effective treatment, but the key is to find the exact place to go in and curette. You could be curetting one space and have a hole that's even bigger, but only 2 millimeters away from it. And you'll do your job properly, but it still won't help the pain. So curettage seems to be the way to go. Antibiotics I use as a diagnostic tool. If the pain goes away or diminishes, then I assume there's some inflammation along with the ischemia. But the anticoagulants, we published a paper where people who did not respond to curettage in the jaws and in the hips, if they did not respond to curettage, we put them on whatever anticoagulant seemed to fit their hypercoagulation state. And with that, people, remember, these are people who are surgical failures. 40% of them had their pain totally disappear, essentially permanently. And then, of course, you could stop diving, estrogen, steroids, whatever. So the treatment is pretty well established. It's the same in the jaws as elsewhere. The problem is finding it. And that's what the ultrasounds are all about. Is it successful? My rate was 72%. I was the first paper that used a pain index to ask patients, an established pain survey to ask patients about the pain after the surgery. And I was also the only paper where the person who did the surgery was not the one who did the report. So there wasn't any involvement or incentive, psychological incentive to say that it's positive surgery. And just about 5-6 years ago, the Larry Goldblatt, who was the dean of the Indiana University School of Dentistry, when he retired, he took on a bunch of these cases, and he did a study looking at all kinds of features, but he had an 82% 5-year pain-free episode. So it seems to work, but for those people who don't get help, it is really, really tough. So I guess now it's time to get back to the group. And if anybody has any questions, I will just be open to it. I think I'm the last one, aren't I, of the day? So we'll assume there are no questions. If anybody wants this, just send a note to boko@aol.com, and I would be happy to give you this and whatever else I have on this ischemic bone issue.
Professor Bucco, thank you so much for your contribution and for your very interesting lecture. Thank you. Thank you so much.
All right. Bye now.
Yeah, thank you. Thank you, Prof, so much for your kind presentation. Yeah. Okay. Yeah, thank you. Thank you, everyone, for your attendance. Dear Professor Marian, shall we conclude today's session, today's conference? Well, if we will be concluding today's session, well, I would like to kindly remind that this is virtual conference InnoBioTech. And a total of 30 speakers from all over 14 countries, from all over the world, are contributing to this conference from November 13 till December 2nd. Well, using this opportunity, I would like to kindly thank to all the members of the organizing committee for their enthusiastic in putting together this virtual conference. The conference chairs for their efforts in managing the conference proceedings, and above all, you and the speakers for choosing the to take time out of their work to support this conference and and present their scientific contribution in the field of innovative biological dentistry. And I would like to kindly remind you that all the papers which are submitted and has been accepted into this in this conference will be published in ISI database. Well, do we have any more questions? So I would like to kindly remind you that we have a session tomorrow as well, which will be starting at 9 a.m. in the morning. So tomorrow is going to be last day of the of our conference. Prof. Marian, shall we conclude and shall we end today's session?
Okay.
Yeah. So
thank you.
Thank you everyone. Thank you for organizing this wonderful conference. Thank you for the technical support, and thank you for organizers for this event. Okay.
Thank you.
Thank you so much.